Good morning. It's a finer morning than that. It's sunny. It's cold, but sunny. Good morning, everyone. I just need the motivation, quite frankly, so thank you. I'm really honored to be opening for the next group of CLPS, the Center for Law and Policy Solution interns. When you say intern, it connotes like somehow not a valued member of our staff, but they are fully integrated here at the Rockefeller Institute, which they get all the benefits and then all the downsides, of course, of doing research. It was an intensive process, and I'm really looking forward to their presentation on reproductive health, which is something that our advisory committee wanted them to look into. First, I think we have some folks from various colleges here. I'd like to thank Dean Rethmeyer of the Rockefeller College of Public Affairs and Policy, not only because I'm a graduate from there and he is my boss when I teach there, but because he is committed to this partnership of undergraduate internships here and giving them an experience in public policy that I think is second to none. So thank you, Dean Rethmeyer. To our advisory committee, Aviva Abramovsky, who is the Dean of the University of Buffalo Law School, Andy Ayers, who's the Director of the Government Law Center at the Albany Law School, Joe Bellick, who's a SUNY Board of Trustee and a U Buffalo Law alum, Matt Ingram, who's a Professor of Political Science at the Rockefeller College, and Tim Taylor, who's the adjunct faculty at University of Albany and also a member of the GLC Advisory Board. They really help guide the process about what the students and the center focuses on, as well as our senior advisors, Scott Fine, who's the chair of the Government Law Center, is here with us today, helps guide us, and Patricia Strock, who is our Director of Policy at the Rockefeller Institute. So I'd like to turn it over to the CLPS interns for their presentation. This is one of a number of things that we've been doing on reproductive rights, given the national mood. Andy Ayers, who's also on our board, has been writing on this as well. And before they start, Katie Zuber, who will come up and introduce them, is our director for the government law, the Center for Law and Policy Solutions. So many acronyms, I get them all confused in my head. Also an assistant director here. She really drives the center in the process. She has done a phenomenal job with this center. She's provided enormous opportunities for many students at the University of Albany and among the SUNY system. So with no further ado, I'd like to welcome Dr. Katie Zuber.
I just want to start off by saying thank you very much for all coming here. I know it's a really busy time of year and you all have busy schedules, so it means a lot to me, and I know it definitely means a lot to the interns to have such a packed room. I want to talk to you a little bit about the center and the work that we do here and what we think we are trying to achieve with this internship program. And then I'm going to hand it over to them for the actual good stuff, and so you can kind of hear about what they've been digging through this semester. Jim mentioned that the center represents a collaboration not only between the Rockefeller Institute and Rockefeller College, but also the Government Law Center and the Buffalo School of Law. And it's our hope that through this kind of interdisciplinary connection, bringing together researchers, social scientists, lawyers, practitioners, that we can develop research that is going to inform the development of good public policy. And so part of carrying out that mission is this internship program. And there's a few things that I think set this internship program apart from some of the others that you might see in a more traditional academic setting. And so one of the things that we are always looking for in our interns is to recruit people who are really early on in their academic careers. So these are internship opportunities that are not just reserved for upperclassmen, juniors, and seniors, but also sophomores. So people who are not necessarily included in these opportunities on campus. We also look for people who will benefit from having this kind of professional experience. So one of the things we pride ourselves on is looking at people's kinds of experiences coming into this internship, and we actively select the people who have worked as waiters, waitresses, hostesses. I believe actually this semester we have one student who helps with her family's dog breeding business, right, but is really interested in thinking about exploring her aspirations as a political journalist. I don't know if that's still the case after the internship. We will maybe have to ask her. But again, these are opportunities for students to really develop their professional skill set and be able to explore these opportunities about whether doing public policy research and analysis is right for them and something that they want to pursue. And last but not least, I think one of the things that they'll say is great about this internship program is that it's a paid credit-bearing internship. So one of our former interns actually put it best. He presented at SUNY's Applied Learning Conference about one of, I think, a handful of students that actually presented at that conference about his experiences in the internship program. And he said that oftentimes a lot of students have to pick and choose between, paid work experiences and unpaid internships. And we try to kind of reduce that by again, giving them this financial incentive, but also giving them academic credit. So one of the unique things also about this internship program is that we really look at these kinds of timely issues that we are seeing play out at the national level and take a focus on New York State to really understand and gain a better understanding of how these kinds of national issues play out at a local level. So how local people in local communities are dealing with these issues that we see on the news every night. So our inaugural cohort in the spring of 2018 looked at the effectiveness of drug diversion courts in the context of the opioid crisis. And as you can see here, these interns this semester are looking at reproductive freedom in the context of all of these discussions that we hear about Roe v. Wade and what is likely to happen in the event that we see a reversal of that particular decision at the level of the United States Supreme Court. So we can sit here and crunch numbers in Albany all day and sit in our nice executive offices, but we don't really understand how these issues are affecting local people and local communities. And that's what these interns are really doing with this axis of reproductive care. Another great thing about focusing on this local level is that it kind of gives them greater access to local stakeholders. And one of the things I really want to commend the interns on this semester, they have talked to people on every side of this debate. They have talked to abortion providers. They have talked to executive staff at crisis pregnancy centers. They have talked to members of the New York State Department of Health. That was an impromptu last-minute 11th hour interview, so we appreciate the Department of Health for accommodating that particular request. And they've talked to advocacy people and organizers. So through all of these kinds of interviews and conversations that they've had, they are providing a more comprehensive picture of what is at stake, particularly here in New York. And so they will, I won't give too much away, but they are really going to encourage us to think about this initial focus on Roe and what is going to be happening in light of a reversal of Roe v. Wade to a larger set of challenges that New Yorkers here face. So with that, again, thanks for coming, and I'm going to hand it over to the interns now.
So we see that abortion has really become one of the most prevalent and controversial issues today in our current political arena, especially in light of the election of Donald Trump. As you see above, he promised that he was going to put pro-life justices on the court, and this was really instrumental in him winning the election, winning over conservative voters. So it's pretty clear that Trump is focused on overturning Roe v. Wade and making abortion no longer nationally protected. And so we have seen that these attacks against legal national abortion and Roe v. Wade have really proliferated and have really trickled down into also our local leaders. As you see above, just our Senator Kirsten Gillibrand expressing her concern about what is going to happen. Fortunately, though, we do live in New York State, which is a very progressive state where abortion was legal prior to Roe v. Wade and will likely remain legal in the absence of Roe v. Wade. But even though abortion may remain legal, that doesn't mean we don't have other concerns. There's so many reproductive services beyond abortion that we need to address gaps in accessing them. And so what we're going to do is we're going to outline the legal landscape for you and address some of the concerns we have in terms of addressing gaps in access to reproductive care.
So Roe v. Wade was the progressive decision in 1973 which gave women the legal right to an abortion. However, decisions after this Supreme Court decision have begun to chip away at that core element established in Roe. The trimester framework was established to give women these protections under certain restrictions throughout the pregnancy. So the first trimester would be the autonomous decision between the woman and her doctor. The second trimester would require state involvement as to protect the life of the woman. And those restrictions were either facility requirements or provider requirements. And then the third trimester was to protect the life of the fetus, and states could outright prohibit the procedure from happening. The courts were said to have moved too fast for its time, which explains a quote behind me from Ruth Ginsburg. And that accounts for the backlash received through society and by the courts themselves. 7 years after Roe was established, Harris versus McRae upheld the Hyde Amendment, which denied women Medicaid funding over an abortion. So it became legal for states to deny funding to poor women. And lastly, Planned Parenthood versus Casey reaffirmed Roe in 1992, completely ridding of the trimester framework and replaced it with the undue burden standard, which didn't accurately explain and give states guidance for what constituted as restrictions. So in result, this opened doors for states to impose their own restrictions and making access more difficult.
So targeted regulation of abortion providers, or TRAP laws, are these laws that aim to prohibit abortion in states despite it being legal in the United States. So these are typically passed in your conservative and swing states, but you do have your exceptions like Maryland, Connecticut, and Rhode Island up in the corner. So there's mainly three types of TRAP laws. One, the first kind, applies to facilities. So these can range from corridor widths to admitting privileges in nearby hospitals. In Texas, this closed over half of the abortion clinics available to people. The second type of TRAP law that you'll find are ones that restrict actual abortion providers. This includes licensing standards and reporting requirements mostly. So in Montana, this had a big effect because Montana implemented a law requiring that only licensed physicians could perform abortions, while physicians' assistants were actually the #1 abortion provider in the state. Finally, your third law are TRAP laws that aim to restrict women directly. So this will usually be an ultrasound requirement, requiring providers to provide an ultrasound. They may have to display the image as well as describe it, even if a patient refuses. So North Carolina defended this by saying that a patient could avert their eyes or they could cover their ears if they didn't want to see the image. But here in New York State, we don't have TRAP laws, unlike more of our conservative and swing states in the United States. And we're really lucky because we seem to be more of a beacon of reproductive rights and abortion rights compared to most of the rest of the nation.
As referenced by this quote, we're fortunate here in New York, even though everything's not perfect. New York was one of the first states to legalize abortion in 1970. The state law is that abortion is banned after 24 weeks, except to save the life of the mother. The state constitution also protects the tenets of Roe. Eric Schneiderman also presented a legal opinion in terms of the penal code that reproductive decisions cannot be diminished by New York's penal law.
So as mentioned by my colleagues before, we're fortunate here in New York State. When we look at this graph, it shows the rates of abortions in the state of New York between the years 2006 and 2016. And what we see is that there's a constant decline in abortions. When you speak to people and providers, a lot of people are attributing this decline in abortion to the increased use of contraceptives, which is a good thing. So what that tells us is that abortions are not the problem here in New York State, and we need to be looking beyond abortions to see what other factors are influencing women's active access to reproductive services. So when we were conducting our research, we came across two health indicators that told us there's still more work that needs to be done. These two indicators were the rates of primary and secondary syphilis, as well as the rates of maternal mortality. When we look at the graph, you see that they are both on an upswing. when we went out and we actually spoke to a provider, they said that they used the word an epidemic to describe what is going on in Rensselaer County, which is not too far from here. She described syphilis as being an epidemic. And we also, when we talk about maternal mortality, we're looking at in New York State, while other developing nations, their rates of maternal mortality are actually declining, right here in New York State, they're actually increasing with African American women and women of the Alaskan Native category actually experiencing 3 times the higher rates than any other races or ethnic groups in maternal mortality. So these rates actually show us that yes, we're doing okay, but there's clearly more work that needs to be done.
One of the broadest systemic barriers in terms of reproductive health care is health insurance and providers. Nearly 1 in 10 women lack health insurance. Even if one is insured, impoverished women are more likely to avoid contraceptive use. Only 3/4 of private insurance companies provide full contraceptive coverage to women. In terms of this graph, uninsured women are also face issues as they are more likely to avoid OB/GYN visits yearly. About 1 in 3 uninsured women visit the OB/GYN, whereas 2/3 of privately insured women visit the OB/GYN yearly. As a result, people, in terms of insurance, people tend to be scared away when doctors' offices ask them to show their insurance card. Therefore, the out-of-pocket system creates a barrier for many to overcome. Reproductive services can't be utilized to their fullest potential if there is a financial barrier for men and women.
So what sets us apart is the fact that we have access, well, that we have so many services. The New York State Department of Health actually funds over 48 agencies that offer reduced or free services for not only women, but also adult men and adolescents. So the services are here, they're here in the state. But the problem becomes when we're talking about connecting these services amongst each other and also people to these services. When you go out and when we spoke to providers, we saw this issue of there being fragmentation across agencies, and also this issue of having inadequate knowledge, both for people who are looking for these services and also for providers of knowing what people are eligible for and putting it out there to them. So all of these actually create an issue for women who are trying to receive adequate care. And when we spoke to the Department of Health, they told us that they rely on providers to put this information in front of people to let them know what they're eligible for. When you speak to providers, they're saying that they have a lack of, they have their own challenges. So they're competing for scarce resources, which can kind of lead to a lack in referrals to other programs. We're also seeing that low salaries is creating a problem of retaining and actually recruiting people to work in these organizations. Then we also have the issue for rural areas where people have to travel almost like 45 minutes out just to get to their closest clinic. And right here in the surrounding counties around us, from Essex to Montgomery, people have to at least travel 45 minutes. And in Herkimer, we're seeing that there's not even a clinic available for people to go. So all of these issues around all the services that we have and them not connecting with each other and not even being able to connect to people creates this gap, and that is where women and families fall through, as one provider said.
So it's important to take into account when giving people access to services, different populations face different set of challenges. So in particular, the younger population, teens and adolescents, they face two main challenges. The first one is confidentiality. A lot of students, well, younger populations, are still under their parents' insurance, so they're reluctant to seek reproductive care that they might need because they're afraid of who will find out. So that puts them at risk of seeking services that they will need to increase their health and reduce the risk of pregnancy and STD rates. The second biggest challenge that the younger population face is a lack of comprehensive sexual health education at not just the national level, but the statewide level. There's a lack of consistent knowledge and language use that will really help younger students understand the health risks associated with certain behaviors. And so it's important to take these two things into consideration when addressing the challenges that they face.
So another problem that we really found was language barriers, which is especially prominent among the immigrant communities. We spoke to one provider who shared a short story with us about a patient who actually was taking her medication incorrectly because she wasn't able to read the label on her prescription bottle. So in this case, obviously, language led to worse quality of medical care, and that is just one instance of this happening. So this isn't just a local problem, this is a really state problem also. 1 out of every 10 New Yorkers has a limited English proficiency. So as you can see, this is a big issue that we need to address that leaks into the quality of medical care you receive. And beyond just being a state issue, it is also a national issue. A recent report found that nearly every physician reported working with patients who were had limited English proficiency, but patients, only half of patients reported that they were receiving some type of interpretation services. So as you can see, there is a tremendous gap here that is leading to worse quality of care. So another issue we found among the immigrant community, especially the undocumented, was just generalized fear. Providers told us that immigration and customs enforcement would sometimes wait outside of emergency rooms, wait outside clinics, because they knew people were going in there. So this was causing fear. So even though immigration and customs enforcement doesn't release the data of where they find detainees, we know that anecdotes, such as the ones we were told, really proliferate and cause fear among the community regardless. For instance, you might have heard the story of a 10-year-old girl who went in for an emergency surgery and then was detained. So stories such as these really scare people away. One recent report actually found that such fear led to decreased participation in Medicaid as well as Children's Health Insurance Program, CHIP. So that means not only were undocumented people receiving worse quality medical care, but so were their children who were possibly American citizens.
So we talked about miscommunication and misunderstanding of information, but sometimes it's actually misinformation, specifically by anti-abortion groups. If you look right now at your phone, you can Google search abortion clinics Albany, New York, and your first result will be Alpha Pregnancy Care Center. So Alpha Pregnancy Care Center is one of 10 crisis pregnancy centers located in the Capital District. They do not offer abortions. They do not refer to abortion providers either. And so these crisis pregnancy centers located in the Capital District and all over the nation are generally Christian and pro-life organizations that aim to dissuade abortion and also promote motherhood and adoption. These are not medically licensed facilities, but they do offer options counseling, referring to the options a woman may have while pregnant. So we went and talked with one of these local centers, and when we asked them, they were very forthcoming that they were not a licensed medical facility, they were not medically licensed at all, and that they never claimed to be. They told us time and again that they want to be transparent, but they stand for what they stand for. Unfortunately, when we checked their websites and when we called unidentified, we found that this disclaimer of their medical status wasn't as forthcoming. It's nowhere to be found on their website, and it wasn't mentioned in a phone call. And so what we really found is that pro-life and pro-choice want the same thing. They want to reduce the number of abortions. But it's really the means of which they go about that differs vastly. So these pregnancy centers advertise factual information about abortions. But when you look at the information that they provide on their websites, when you talk to these people in person, when you talk to them over the phone, look at their pamphlets, you find the information you're receiving is plagued with medical inaccuracies. Just one local center's website lists under the medical risks that fetal parts may be left inside the body, that damage to internal organs may occur, death, depression, flashbacks of abortion, suicidal thoughts. Again, these are just a couple of the dozens you can find. And so this causes unreasonable fear in people considering abortions. And this deters people from making properly informed decisions with accurate information, which frankly they deserve.
So right now we're at a pivotal moment in New York State where we can kind of decide what kind of state we want to be. You know, as one provider mentioned to us, they're looking towards policymakers for the future. So now we're going to outline some of our proposals on how we can address these issues and hopefully create a better reproductive health future.
In terms of pending legislation, these recommendations can be made. Passing the Reproductive Health Act is important as it moves abortion from the criminal code to the public health code. It will no longer need to be a part of New York penal law, for example. It will let women make private decisions about reproductive health care. As for healthcare reform, there are two separate recommendations. One is a bare minimum, which is the Comprehensive Contraceptive Coverage Act. All health insurers have to provide cost-free contraceptive coverage as part of their insurance policies. Research shows that providing free contraception reduces unplanned pregnancies and abortions. However, there are two flaws. It doesn't encompass all reproductive health care, and it also doesn't focus on improving conditions at reproductive health facilities. Therefore, the ideal pending legislation is the New York Health Act. It is a publicly funded healthcare apparatus which ensures coverage for all. Every New York resident would be eligible to enroll regardless of age, income, wealth, or employment. It combines state funding with federal programs already in place. If this is enacted, it greatly reduces out-of-pocket payments for New Yorkers, both in reproductive and general health care.
So when we think about how we're going to combat this issue of connecting services, the first thing we want to think about is changing the school of thought around women's reproductive services. So when we spoke to one provider, they kind of said that women's reproductive services is kind of pushed out of the umbrella of primary care, and it's under its own wing, which ideally it should be a part of primary care. All women's services should be a part of primary care. So we have three distinct recommendations that we think could help improve this. The first would be to enhance the access to services. So what that means is we want to be meeting women where they are. So that means providing same-day appointments or next-day appointments. Also, physicians offering sliding scale fees. Sliding scale fees, as well as thinking about subsidizing transportation to make it easier for people to get to their appointments. The second is to improve communication among providers. We believe that providers should be meeting regularly. This would increase communication between providers and also foster better relationships between them, which we believe would help in referrals and seeing those numbers improve. We also believe that these partnerships should be interdisciplinary. So we don't only want to see reproductive organizations and services have a say on this, but we believe that behavioral organizations as well as health organizations should have a say in how we can all work together because their input, it matters. And third, we want to address the challenges of providing to underserved communities. So we were we came across telehealth, which we believe is a tangible solution that we can do right here in the state, especially for rural areas where they have to travel, like you said earlier, far out to get these services, and that would mean having a compact office in a location that provides computer communication. And so that would really just give them a closer area to access these services where they are still able to get the full range of services. And we also want to think about incentivizing physicians to work in these underserved communities. We're thinking from anything from loan forgiveness to increasing wages, just so that we can find a way to get more physicians into the areas where, frankly, no one wants to be. Yeah.
So when it comes to addressing the language needs, we have kind of a dual proposal. So our first proposal goes along with what Vanessa was talking about when it comes to telehealth is creating kind of a system of remote interpreters who can provide translation services for people who need it all across the state. So California actually began experimenting with this and saw that it was incredibly successful, having a database of interpreters. So since they began this program, they found that misunderstandings based on language decreased by 2/3. So obviously this is really working, and we could definitely use this model in New York. Furthermore, one recent study found that providing interpretations at hospitals led to $161,000 a decrease in monthly expenditures. So hospitals were saving a ton of money because there was less readmittance of patients due to confusion, due to them not actually getting better. So as we can see, there's really a medical, ethical, and financial incentive to make this change. We also think that the Albany Law Clinic, Albany Law Immigration Clinic, does a really great job at addressing language needs. So we think the idea of matching up bilingual students with sectors that need bilingual services is a really great way to address the need. And also this would be little to no money for the state, and it would just be a great educational experience for students. So we definitely think what right now they're doing in law could be carried over to the medical field.
So in order to address the confidentiality issue that exists among the younger population, we suggest creating youth-friendly environments in reproductive clinics or even in health facilities that can connect younger generation to reproductive services. Planned Parenthood actually has a teen clinic waiting room where younger teens can sign up for health insurance and navigate the very intimidating process. And then the second recommendation to address the inconsistent education that exists among younger populations is to mandate comprehensive sex education across the state. New York State currently doesn't mandate that there's a sex ed programs. They do require certain requirements, but they're not enforced as they're based on community need or preference. So this will really address the gap that exists that really exacerbate the issue and put young teens at risk.
So people deserve honest and truthful information regarding their health. And reproductive rights, reproductive services, and reproductive health should be no exception. This is why we suggest that New York State implement a state-level law that requires pregnancy centers disclose their medical status. This would concurrently serve the right for truthful information of the public, as well as serve the pregnancy center's right for freedom of expression. When you look at you can look at a New York City Local Law 17, implemented originally in 2011 and updated in 2016. This Local Law 17 requires that pregnancy centers post disclosures in windows, online, in advertisements, as well as verbally about their medical status. So this was a great step by New York City, but it lacked some enforcement as many crisis centers in the city still don't have this requirement on their websites or in person. This is why we suggest that New York State implement similar legislation to Local Law 17 of New York City, but also establish a clear path of enforcement, proactive enforcement, unlike we had previously. So this would be enforced by the Consumer Assistance Unit in the New York State Division of Consumer Protection. Within the Consumer Assistance Unit, we suggest that a consumer information enforcement entity be established. They would be responsible for investigating claims made against centers, as well as independently monitoring facilities, advertisements, websites for all of the things that they need to be regulated for in compliance with state laws.
So to conclude, this is really a time of great national uncertainty. We have seen the balance on the courts shift, and if a case were to come, it's likely that Roe v. Wade would be overturned. So really concern and fear regarding this is warranted, but we really need to make sure that we recognize that we're fortunate to live in New York State, which is a really progressive state, and we're likely to be okay in terms of legal abortion. But just because we'll have legal abortion doesn't mean that we'll have access to all these really important services that we need. We need to make sure we understand that legality does not equate care. And so we need to keep working towards addressing the gaps in access to care so we can work towards producing a better healthcare system, guaranteeing reproductive health care for everyone, and ultimately just being a national leader on this subject matter. And thank you everyone for coming.
Thank you guys very much. That was a really great presentation. I had a conversation with Jim this morning about who was actually going to introduce the interns, and it was decided that I would do that. And then I realized I came up here and talked all about the internship program and didn't actually formally introduce the interns. So from your right to your left, we have Florencia, Vanessa, Katie, and Katie, which made my life a lot easier this semester, and Megan. So I apologize for that, but this is our spring 2009, what year is it, 18 cohort. It's been a long semester, what can I say? And so now we actually have some time here for question and answers. I believe Michelle actually has a mic. So if you have any questions for our interns, and I really encourage you, definitely press them on their research, talk to them a little bit also too about their research process, what that was like, and give them an opportunity to tell them how great it is to work here at the Rockefeller Institute. So I'll turn it over to you guys for questions.
No, I yield.
Well, first of all, that was great. It's not easy to do this for people who actually have this job for a living. So the fact that you can sit here in front of all these very tough-looking people and present is great. I want to turn to what you were saying, which was the social media element. Access to actual information, I'll defer to my right honorable colleague who's the lawyer. In some states, you talked about the red states, whether you were pro-life or pro-choice, I think you're talking about you have that right in the country, and so what's actually going on in states. There's de facto problems and there's de jure problems. In the southern states, they just try to ban it, right? They find all legal mechanisms. But what you were mentioning is actually a more insidious version of what's going on. If you click in information and say, I want access, but information pops up, you're assuming that information is for the information you're looking for. I think that's a harder problem, quite frankly, to solve, even with disclosures. And that applies not just to reproductive rights and reproductive health services, but to like our democratic principles. How do lawmakers, policymakers go about addressing a problem like that? Because I think if you're a person in need of reproductive health services or Grubhub or anything else, you do Google it, and you're assuming the information coming up is actually true, legitimate, honest information. But what you're really saying is, it's not that at all. So how do policymakers get at something like that? I'm actually asking for a friend.
So yeah, disclosure notices are not a end-all be-all solution. They are a step, though, to make sure that people know what they're getting themselves into. And these centers generally pop up in low-income and immigrant communities. So they do prey a lot of times on people not understanding information. Like we talked about, there's language barriers in the medical field. There's also these language barriers at these centers. We even talked about that with one of these centers. The act, a disclosure notice would help because it would be posted in Spanish and English. So that does solve one of the issues. That's the New York State local law. New York City local law 17 does require it be in both languages. But beyond that, what's important is that we inform people. We talk about sex ed. And so all of these things together will hopefully bridge that gap because you're going to have your sex ed, you're going to inform people of what is medically accurate, and through those resources, they also have facilities that are medically licensed. And it's really a issue of education, educating the public, educating them while they're young, hopefully, and then providing enough information that when people need it. You never want to infringe upon anybody's right for expression. And so that's, these centers have their rights. These centers have their right to speak what they would like. We just want people that are going there to know what they are receiving is not medically accurate. That it could possibly be medically inaccurate because it is not medically licensed. But really, to bridge that gap, like I said, it's the combination of education and disclosures.
Well, thank you so much. By the way, there's a question at the end of this preamble, so you have to I've attended several programs on reproductive rights, and this is by far and away, and I'm not saying that because of any relationship, the best I've heard, and in some measure because it was your mastery of the information, which is quite remarkable. The fact that the underlying data drove your research. There was no opinion, no speculation. And the third, which gives rise to my question, is you're like journalists. You went out and you interviewed people. And lawyers have a sterile it's very good. We just look at the data inside the libraries. And it proves that researchers, you have married raw data and then your own experience, anecdotal experience and interviews. Is that, did you feel comfortable doing that, asking people hard questions? Did that inform your research? Did that cause you to go back to the data and ask questions about the data? And so it's really the process. How did you go about doing this remarkable thing?
I'll take it. So we were really fortunate to have Katie, who led the first initial interviews to kind of model them for us. And we kind of crafted questions together. We definitely wouldn't lead with top controversial questions, save those till the end. And yeah, it definitely informed our research. It was kind of like a feedback loop, something that a provider would say, we'd look into it. And then maybe that would inform another question at another interview. So it was definitely always informing our different experiences and always complicating everything. But it was, I think it was really fruitful experience, the field work.
I do have a request. If research doesn't turn out to be your day job, would you consider practice law?
Definitely.
Not too many lawyers know.
Big documents and the editorial page editor with Times Union. That was just a great job. Thank you. I had a lot of little stars that I want to take back to the editor and say, hey, this is something you ought to look into. But the main reason I'm here today was the Reproductive Health Act. And I was just wondering how deep you got in the weeds of that, particularly the impasse that seems to be in the legislature. Excuse me, in the legislature.
Well, it was like a lot of the things, thank God there's nobody in the Senate here today, is that they keep passing over and over and over again in the Assembly, but not in the Senate. I think it was 2016 to 2018. and that it's just kind of like because we have the new Senate now, so hopefully we can pass it at this point. And what was your other question again?
Um, sorry. Just I guess how deep you got into the disagreement of it, and whether any of the arguments that have been made, in particular against it, stand out.
To me, it's kind of a tough thing to be quite honest. For me, a lot of the more issue I had with the pending legislation I had between the Contraceptive Care Act and the New York Health Act, because in each of our interviews, Planned Parenthood, for example, keeps saying the Contraceptive Care Act, but it doesn't cover all reproductive health services. And in terms of Reproductive Health Act, I think personally that it's a step in the right direction to at least put it in the public health system. And another thing is that in terms of, there are no exceptions for fetal abnormalities, which is a major issue, I think, because it's sometimes they're not going to live long anyway, and it's putting unnecessary burden on the mother, and they have to go to other states in order to get that care.
If I could just follow up on just a couple of things that have been said about it, whether or not you came across. I don't know if you had a chance to read it in real depth and all that, but so a few of the things that have been said about the Reproductive Health Act is it's a radical expansion of Roe v. Wade, a radical expansion of abortion, that it will allow non-medical providers. And I was particularly interested, I think somebody here mentioned earlier that in some states, physician's assistants have been banned from doing abortions. I didn't know they were allowed to do abortions. Would that be, I don't know how the RHA would treat that. And the last one, and the thing that has always amazed me, was the claim that it would allow abortion up to the day of delivery. That's one of the arguments also for I'm just wondering if you came across any of those issues, looked at them, and either are they, is there a grain of truth in them? Are they totally inaccurate?
Well, I think they exaggerate sometimes, to be quite honest. I mean, I can understand their concerns of the expansion because it's a very touchy issue, abortion. But I think it would ultimately be a good thing to, at the very least, move it to the public health sector instead of to the criminal sector. So we can, if we do want to make expansions, I think that would be the best place to put it.
Thank you.
Hi, Carl Rethmeyer, the Dean of the Rockefeller College. So first of all, very proud to see the work that you've done. This has been a great partnership with the Rockefeller Institute, and it's great to have our alums also who are leading this project. So real kudos to all of you for the output here. I have two questions. The first one is, in the work that you did you look at what role pharmacological abortion might have in expansion of access to things like RU 486 as a way to hurdle some of the issues with access that come from place, that come from distance, that come from access to facilities? And did you have thoughts and where that might fit in the broader set of ideas that you're thinking about here?
Actually, I think that's a great recommendation. I would say that we didn't actually in the that's a hard word for me to say. I'm not even gonna lie. Pharmacological. We didn't really do. We didn't kind of actually just look at that, but I believe, based on what you were saying just now, I feel like that it's actually a great recommendation. And when we were talking about telehealth and having this idea of a compact area where people can access these services, I feel like we could find a way for pharmacies to play a role in that as well, to kind of cut down exactly what you were saying, the cost, the time it takes to get to places. So I actually feel like if we had a little bit more time, that is something that we would definitely look into.
I just wanted to add, in our interview actually with Planned Parenthood, they brought up about how desperate women sometimes order online the pharmaceutical abortion pill, but they don't know what they're getting. and you need to actually go to a doctor and take it, and a doctor needs to watch you swallow it, and you know. And so we see how women are actually searching for that, and they want that, and so that's definitely, an interesting step.
The second part of my question really goes to thinking about how you go from the ideas that you've been talking about here. So you've talked some about the problems of moving things through legislation. So I wonder if you have other thoughts about how other forms of political activity might help move this forward. Is part of what needs to happen a change in how people are organizing in New York State or nationally in order to advocate for these things, or are there missing organizations that might help to move this forward? This is obviously a very mobilized area in politics, but it hasn't actually come to fruition here in the state. Some of the revisions that you've talked about. So, have you thought some about how the underlying mobilization of interest groups or people like you might be able to engage differently to get a different result?
So we did talk to an advocacy organization. Um, there are plenty of advocacy organizations, and they're out here pushing and they're promoting. But they can only do so much, and providers can only do so much themselves. So that's kind of where we found there was a disconnect in what we were talking about. That there were these things that providers could do themselves. They're reaching out to these people. There are services. There's things like vans that go pick up people in rural areas. There are, like smaller versions of telehealth. But providers and advocacy can only bridge the gap so much. It's kind of a meet in the middle kind of thing, where they can't do it themselves. They need help from state departments. They need help with legislation. This doesn't have to all be in the form of legislation, but it does have to be somewhat policies. Whether that be just through funding or programs. It doesn't have to be a law that passes through Senate.
Congratulations on great work. And by the way, there's a great BA MPA program you should check out.
Hi, congratulations. I hope you can take a deep breath now, right? I want to follow up on two particular issues and ask if you have a body of work or enough data to give some further information around the ICE outside of the clinics and ICE agents. And the second would be the language translation services, because recognizing that's such a critical component. How much work do you have on that, and can you share some more on that?
Sure. So, as I mentioned, ICE doesn't release where they find people for detainment purposes. We do see that ICE detainments are on a rise, and so from that we can kind of extrapolate that ICE detainments based from medical clinics are also in the rise. And we've also seen how with the current administration there used to be kind of a respect more for medical centers, but now that's kind of going away. And there's dozens and dozens of anecdotes of ICE going into hospitals and medical clinics and taking people, having them under intense surveillance while they're trying to receive care. So we do see that that's an issue. Unfortunately, that's a federal issue where we only have enough data as the data that they will release. So we should definitely put more pressure on them to release more data.
So are you saying that most of the information around that particular topic was anecdotal, do you think? I mean, based on extrapolation of what's going on nationally?
Yes.
Yeah. Okay.
Yeah.
And then the language translation?
So in terms of offering language translation services, so we do see that kind of like these telehealth initiatives kind of popping up into like sections of different states and cities where they see need, like California, Arizona, with really high immigrant populations. But as we mentioned, these kind of like these citywide solutions or countywide solutions tend to leave out people. So one thing we talked about also was possibly creating a proposal based on a percentage of immigrants that live somewhere. But we found that was also problematic because undocumented people usually aren't in those percentages. So we think a statewide solution would kind of cover all of our bases.
Hi, Matt Ingram from the Political Science Department at UAlbany. Congratulations. This was really fantastic. I was really interested in the segment. I was interested in a lot of things, but I was interested in the segment on crisis pregnancy clinics and wanted to circle back to the question about information, access to information, the truthfulness. It's sort of another layer of the post-truth society that we live in. But there was a case that reached the Supreme Court last year out of California, right? That was very similar, raised some similar issues, and it raised issues about the free speech protections of the crisis pregnancy clinic, right? But then also about whether passing any laws at all would unreasonably target those clinics. And so I was wondering if you thought about your policy recommendation, right, about some kind of legislation in light of what the Supreme Court has already said about this, right? I mean, they're not. I wouldn't say they're hostile, but they're definitely unfriendly to this kind of legislation. Um, and then also, there's a string of cases more recently that seem to be marshaling protecting individual liberties like free speech or freedom of free exercise of religion at the expense of other rights and liberties, right? Sort of elevating free speech and free exercise of religion over other substantive rights. So I was wondering if you thought about that issue in light of these other national trends.
So absolutely. You're referring to NIFLA, National Institute of Family Life Advocates versus Becerra, 2018 Supreme Court case came out this past June. So that does, it related to a very similar law that California had placed. California had placed two restrictions. One on non-licensed facilities, a similar disclosure requirement, as well as requiring that all facilities, particularly pro-life ones, was the argument, to also post notices that reproductive services were available through California, the state. So the Supreme Court struck down both of these laws in June. And the first one is they struck down, the first one being the fact that they had to disclose what California services had to offer, was struck down because it claimed that these pro-life organizations had to promote services that included abortion, which they are inherently against. So that was struck down because it was said that they were inhibiting their freedom of expression, freedom of right to speech. The second regulation on that was a disclosure notice. This was struck down also by the court because it was said that California, it was only a hypothetical problem in their case. But if it weren't a hypothetical problem, that it would possibly be a different scenario. And that was the reason that was struck down. So this is a different case, though it's definitely similar. So there was a case of against New York City regarding this law. It was the Pregnancy Care Center versus City of New York, and that was in 2014. And this was decided by the Second Circuit in favor of New York City upholding these laws. So this is a valid law held up by the Second Circuit. And the Supreme Court saw this case and they declined to hear it. So this is also, not a direct ruling, of course, by the Supreme Court, but it is a ruling for them not hearing it. They're not going to overturn this. They let the Second Circuit decision hold. I hope that answers your question. That was 2014. And this law is from 2011 originally. It's been updated since, updated as recently as 2016.
Hi, I was particularly interested in the conversations around sex ed and, of course, the complicated and difficult issues around crisis pregnancy centers. Sex ed, it would be wonderful to have a lot of people working on sex ed in the state of New York. It's been an ongoing battle that's gone on for many years and gets stopped for many reasons, but new voices in it would be most welcome. Thank you. On the crisis pregnancy centers, again, complex, been worked on for a long time, many conflicting issues on it. But Ireland dealt with it in a different way, or I don't know that they dealt with it, but they started to make a dent in it in a different way because they referred to them then as phony pregnancy centers or faux pregnancy centers. And so in marketing, you can do what you may not be able to do in the law, which is make it known to people that these are phony centers, not crisis centers. I'm just giving that for you to think about.
Actually, in one interview we had with Planned Parenthood, they told us they're trying to remarket them as anti-abortion counseling centers to be as explicit as possible, and that was the language they are now going by.
Yeah, I mean, if you look around, they're often referred to as fake clinics. You know, we're we're trying to understand these clinics because they do have genuine interests. It seems because we talk to these people. They have other services. It's just really we're concerned about what services they're not providing and what services the clients who come there think that they may be providing, and whether that's really clear. And so, I mean, I completely agree that there's definitely public support and advocacy and how we frame these things can definitely help people understand maybe what they're going into. And that's also part of sex education.
Hi, Barbara Thomas from the League of Women Voters, and I actually wanted to respond to something that Jay Jacknowitz had asked, because the Reproductive Health Act would allow medical people to practice abortion within their scope of practice. So it doesn't restrict it to physicians, but it would allow appropriately trained other medical personnel to provide that service. So it is different than just letting, say, podiatrists or, you know, it has to be within your scope of practice and your training, whether or not you're there. And I do want to compliment all of the students for the depth of the research that they did, and particularly the interviews. It seems like you've gathered a lot of information about the difficulties, and particularly I'm interested in the transportation issues because I happen to have a summer home in a county, Hamilton, that has no pharmacy. So, or for that matter, full-time physician.
All right, so again, I just want to say thank you very much for coming out today and for supporting the interns and supporting our program here, and for all of the really great discussion. Again, thank you to you. You all did an absolutely phenomenal job. It is very different for undergraduates to give a presentation to a room full of people from Planned Parenthood and the Department of Health and the Times Union than it is to give a presentation just in front of your class. So I really commend them for the excellent job that they did today, and thank you all very much for coming.